All right, so hello everyone. My name is Nick Montano. I'm a third-year medical student at UC Davis going into emergency medicine. I'm going to be presenting an article for the National Ultrasound Interest Group on the association between optic nerve sheath diameter and mortality in patients with severe traumatic brain injury. This is a paper from 2014 by Pinder et al. I hope I'm saying that correctly. The paper really wanted to evaluate if there was any type of independent relationship between optic nerve sheath diameter and mortality in patients with severe traumatic brain injury. And so what they did was they did a retrospective cohort study for across about 6 years, looking at ICU patients at 2 different centers in British Columbia. These centers had, faculty, fellows, and also ICU level specialists. And they had a couple of different data points. Most importantly, they used optic nerve sheath diameter measurements on CT scan to evaluate a correlation between the severity of traumatic brain injury by way of ICP monitoring. So the inclusion criteria for this were traumatic brain injury patients by a closed mechanism. Any patients who had open or penetrating injuries were excluded. And they also needed to be in the ICU requiring continuous intracranial pressure monitoring. The measurement on CT scan of the optic nerve sheath diameter, which I'm going to just from now on call ONSD to shorthand it, this was done by 2 investigators, so only 2 physicians were doing this. They were not involved in any of the data collection, and they were blinded to the patient's condition. They used the same machine, they used the same protocol, and the standard protocol for evaluating ONSD on CT scan is to scroll through a 16-slice image of a non-contrast head CT and find the image that shows the best or the widest optic nerve sheath, and then measure measure the diameter of the nerve sheath from 3 millimeters posterior to the orbit. So that's kind of a standard measurement using electronic calipers. That's been validated in other studies as well, so it's a very reliable tool. So these 2 physicians went through, they measured a total of 220 patients and collected data on them. And these patients were from a variety of different areas, most of which were male. But as far as their mechanisms of injury, there's a variety from motor vehicle, cyclists, there was accidental falls, pedestrians that were struck, and then a few others as well. And they took a bunch of different data to correlate with the ONSD. They looked at pupillary responses, Rotterdam scores, Glasgow Coma Scale, blood pressure, and so on, and also looked at the mean ICP because, again, all these patients had ICP monitoring in their ICU stay. So there were 19 patients out of the 250 that were excluded because they had a penetrating TBI, and then there were 11 that did not end up with an ICP or an intracranial pressure monitor at any time. So of the patients that remained, there's about 220. What they saw in the relationship between the optic nerve sheath diameter and the ICP was that there is a direct relationship between optic nerve sheath diameter and increased intracranial pressure. So for every 1 millimeter of increased optic nerve sheath diameter beyond 4 millimeters, we saw a direct relationship in increase in ICP going from 0 up to 20 and then beyond that. And anything greater than 20 millimeters of mercury for intracranial pressure is considered pathologic, and in this context, consistent with traumatic brain injury, increased ICP. Another endpoint that they looked at was the optic nerve sheath diameter as well as mortality, and it was shown that there was a 2-fold increase in mortality per millimeter of optic nerve sheath diameter increase in this patient population. Let's see.
Nick, in the paper, were you able? Did they report, how? What was the timing of when they got the scans from when the trauma occurred?
They did. So all of the scans were obtained within 48 hours of admission. So this is pretty close to their initial ED presentation. Not at the ED, but within 48 hours. So there is a little bit of wiggle room from the emergency setting versus the ICU setting in terms of this measurement.
Sure. So they had the injury. They were evaluated in the emergency department. They went up to like the neuro ICU or the trauma ICU, and then they got the CTs sometime after that.
Correct.
Okay.
Yeah.
Okay. So did you identify any major issues with this study, or do you think this is going to be applicable to us in the emergency department?
The only things that were somewhat concerning was that there were only two clinicians doing these measurements. Now, looking at other studies, optic nerve sheath diameter is well investigated in terms of how to perform the measurement, how to take the measurements. That's all very data-driven and has a good literature background. But this study only had two investigators. I'd like to see more people doing this for inter-rater reliability. However, assuming that this is reliable methods that they're using of collecting the data, I think this can definitely extrapolate to the emergency setting, given that we have CT readily available. This is a non-contrast study. These are for patients who present to the ER. I think it's definitely something that we can use in our setting.
Yeah, I like that. That they measured it the same way we do with ultrasound, which we're going to talk about next. So it helps, kind of validate how we do it with ultrasound. I think that the timing is the one question I had, because 48 hours is pretty soon after the injury, but it's well after we would evaluate them in the emergency department. So you would probably have to repeat the study, I think, to kind of get a earlier CT head, which we do all the time. Seems like it'd be an easy study to do, to see whether this still proves true, or maybe it takes a little bit of time for these optic nerve sheaths to actually expand. I think that's a question that may need to be addressed.
Yeah, I agree. It'd be really interesting to see what happens if we looked at their CTs at the time of presentation to see what's going on.
Mm-hmm. Yeah, maybe compare those with 48 hours later, something like that. And I think it showed something that we already knew, was that if you have a bad trauma, bad head trauma, your ICP is going to go up, and of course that going to lead to a higher mortality. But It was interesting that seemed like they were able to correlate it with as the value went up. So that's something I haven't seen before.
Yeah, another thing that I was kind of thinking about was these are all ICU patients, so they're the sickest of the sick. I wonder how much this can apply to patients who do have a traumatic brain injury but are not developing their symptoms or their presentation as severe as quickly. So for maybe the mid-level trauma patients, is this still valid for them?
That's a good point, because that's often one of the confounders of these studies, where the patients may be so sick that you could look clinically at them and you're like, that their ICP is high. But This may not be the patient population we really care about. It may be the patient population we care about are the ones that are not obvious on exam, the ones that we really want to know, do they have a traumatic brain injury now? I want to know this now before I address all their other traumatic issues. That's a good point. Okay, cool. All right, so should we move on to the next article?
Yeah,
let's do it.
All right, Max, why don't you just introduce yourself as well? And I'm Michael Schick. I'm faculty at UC Davis in the emergency department.
My name is Max Stevenson. I'm a third-year med student at UC Davis in California, and I'm going to be pursuing a career in emergency medicine. So today I'm going to be reporting to you, reviewing an article called "The Use of Sonographic Diameter of Optic Nerve Sheath to Estimate Intracranial Pressure," publication from 2013 in the American Journal of Emergency Medicine by Amini et al. So in contrast to the previous review that you heard, I'm going to be taking a look at comparing ultrasound measurements of optic nerve sheath diameter with measurements done on LP to measure the ICP. So what this paper was kind of trying to address was that, increased ICP can result in neurologic injuries that really need to be promptly diagnosed and treated. And so they wanted to evaluate, because with current methods, you may have methods clinically that might not be accurate, ways to measure it that might include lots of radiation, or there may be methods that are really invasive that we're trying to minimize. So the objective that they were trying to kind of get after was whether the efficacy of sonographic, I'll call it ONSD from now on, optic nerve sheath diameter, whether sonographic ONSD is useful in estimating ICP through comparisons with lumbar puncture findings. So the hypothesis is that there's a correlation between this ultrasound measured ONSD and actual ICP. So this study was a small descriptive prospective study of about 50 patients, where they compared ultrasound measured ONSD immediately before an LP in a non-traumatic patient who was going to necessitate an LP, with the ICP measured by an LP within 10 minutes after that ultrasound measurement of the optic sheath. So their primary outcome was really what's the size of the ONSD measured by ultrasound. So how did they measure it? So they had a senior emergency medicine resident who'd been trained by a radiologist in kind of all the standard techniques that you would be using in order to measure this portion of the anatomy. And then within 10 minutes, they had a radiologist, or excuse me, a neurologist, neuroresident, who would come and perform a lumbar puncture in order to obtain the opening pressure at that point. So all their measurements seem consistent with what we'd use clinically and in terms of their imaging and procedures to measure all of these findings. In terms of the population, the people that they're looking at. So they're not looking at, they're excluding folks who had a traumatic brain injury. They're excluding folks who have some history of medications which influence their CSF pressure. They also excluded people who have conditions that affect their eyes as well. So we're not looking at those populations, but we're looking at non-traumatic, hemodynamically stable patients who have an indication for an LP. So, if you wanted to look at the data, they analyzed it by essentially just looking at the mean ONSD for people who either didn't have ICP increase or did have ICP increase. And then they also used some Pearson, what's called a Pearson test, to evaluate for a correlation between ONSD and ICP. Their sample size is 50. Of these patients, only 14 ended up having apparent increases in their intracranial pressure. So rather small sample size, and I think that's important to keep in mind. When we look at the data and see what the results were, it looks like this ONSD has a strong correlation with intracranial pressure. The mean ONSD for the patients with increased ICP for normal individuals were around 6. Whereas, for the folks with increased ICP was around 6, whereas for those who were normal individuals without increased ICP was around 4.6. So, and these differences were statistically significant. So we ended up finding that when you wanted to have some sort of cutoff point to say above this point we think people have increased ICP because of their ONSD, or below this point we think people don't have increased ICP because of their ONSD, 5.5 is kind of that magic number. So if you take a look at table 2, it shows that when they put their cutoff point of ONSD at 5.5 millimeters, that predicated ICP values of higher than 20 centimeters with a sensitivity of 100% and a specificity of 100%. So in sum, this is a pretty great test to evaluate for increased ICP using ultrasound to assess for optic nerve sheath diameter. Main conclusions by the authors were that this can be considered a strong predictor of increased ICP, high sensitivity, high specificity, and it's less invasive than a lumbar puncture. It's also highly available, fast, and has, like we said, high sensitivity, high specificity, and it's not as invasive. Things that could be maybe some pitfalls in this study. It's a rather small sample size. The authors also covered all the costs associated with getting ultrasounds for these folks, so that could lead to a potential bias. But really, I think if you just took this study and you emulated it and replicated it with bigger sample sizes and you found similar findings, I think this could change the practice of emergency medicine and initial evaluation and treatment of people with suspected increased ICP, because you can perform such a quick, fast, easy test without the need for invasive procedures or radiation.
Yeah, I like this study in that most of the ones I looked at are usually with traumatic brain injury, and they're putting invasive monitors, in people's heads to kind of compare that with what they're seeing on the optic nerve sheath diameter. So this one they measured opening pressure, and I thought that was a pretty nice study design.
Yeah.
I agree with it's a small sample size, and they had basically like one trained person that was doing this. And so, whenever I see results of 100% sensitivity, 100% specificity, it usually tells me that the person, as long as they didn't doctor any numbers, right, which I don't think they did, I think it tells you that the person doing this, doing the exams is just really good. So I think, can we all be that good is another question. And so I perhaps, but I think it's probably a person that, they had some specialized training, they probably had a lot of practice at it, and they got really good. So it'd be also be an interesting study to kind of take novices, put them through a training, and see whether there's some inter-rater reliability of doing this exam.
Absolutely.
So so good, very good. you guys have done some, work in trauma and places like that now. Do you guys feel like this would be able to be incorporated into practice? And where do you think this could, be in emergency medicine?
Yeah, so I think the decision to even kind of look this up on Max and mine's end, we're both on our trauma surgery rotation right now, and we're, helping out a lot with the resuscitations and seeing them come in, and we're doing a lot of e-fasts. These patients have chest and head trauma. They may not have time to go to the CT scan, so would it be possible even to incorporate this into an e-fast, maybe an EE-fast, where we're looking at, ONSD if they have legitimate head trauma that's of clinical significance. So that's kind of where I'd like to see maybe more research into, I agree with novice learners, bigger sample sizes, but also just kind of in that secondary survey of trauma cases. I wonder if that would yield any game-changing information for us.
Yeah, the EO fast, right?
Yeah, there you go.
Yeah, I mean, if you've already got the ultrasound machine out, you're using it, all you really need is just some sterile ultrasound jelly and toss it over the eye to take a measurement. So all I can see it doing is, improving patient care. The question is it going to improve the care for enough people that's going to make it cost effective and, energy and time effective as well?
Yeah, I'd like to see that study, doing a quick scan of the eye and, before they go to the scanner and seeing whether we can rule out, significant intracranial damage. I think, because I think if we may not rule out everything, but if we could rule out those ones that need a surgical intervention, that would be really useful information. Because we do see those patients that are too sick, or we have to make a decision of do they go to scanner or go to the operating room. Great. And any other final thoughts? And I have a case I was going to discuss very briefly where I used this pretty recently.
I mean, final thoughts for me, just doing the lit review on this, there's a decent amount of data showing, not even beyond what Max and I found or presented today, just showing the reliability of this. So I agree. I think the next steps are how can we implement this into our practice to help our patients quicker, faster, more efficiently, and honestly cheaper.
Mm-hmm. So I was practicing in Central America for a short period of time, and I had a 7-year-old come in to the emergency department, and she came in febrile and in status epilepticus. And the seizures, though, were pretty focal, so she just had sort of right-sided shaking and had a fever. The mom reports that I was just feeling ill for a few days. So resources are limited there, and but they do have a CT scanner. But unfortunately, a CT scanner at that hospital is broken. So the only way to get this child to a CT scanner to scan her head would be down the block. So not far, but would have to take her out of the emergency department down the block. So we kind of stabilized her, intubated her, and the pediatrician it was actually a neonatologist came down, and wanted to do a lumbar puncture right away on the patient. And I was there helping out, and I kind of vocalized, I don't know if we should do a lumbar puncture because in the setting of a fever and focal seizure, kind of worried about a brain abscess or a brain mass or a brain bleed or something like that. Not just what would be most common there would be meningitis. So I know that's what she was concerned about, but the seizure was so focal. So we had an ultrasound machine. I ultrasounded the optic nerve sheath diameter, and it was over 7 millimeters on both eyes. And so with that information, I mean, it's amazing. I was able to convince them, the intracranial pressure, it's got to be high. It is a bad idea to lumbar puncture this person. And in fact, I was right. So we stabilized, and the next day she was able to get a CT scan at that hospital. And unfortunately, she had a large mass with bleed. So the patient, survived for the time being, although didn't do very well. But, it's really practice changing in that moment. So I think right now this is very useful in a resource limiting setting, or in a setting where, you don't have that CT immediately available, or the patient's just too sick to get the CT. Other studies I've looked at, the sensitivity of this exam really changes on the value used. So if you measure the optic nerve sheath, optic nerve sheath diameter to be 5, 6, or 5.5 centimeters, you have to choose what you use as the cutoff to call it large, right? So you might say it's large if it's more than 5 millimeters. I said centimeters earlier. Or maybe it's large when it's over 5.5 millimeters. The sensitivity changes as you change that value. So the smaller you make the value, the more sensitive it's going to be, but then you're going to have false positives. So the measure that they arrived at, I think in Max's paper, is 5.5, and that's the number most of us think about. So I think that's the kind of safe value to use, but I don't think the sensitivity is 100%, even though that study says that. I bet the sensitivity is more like 90 if you kind of put all this literature together right now. So 90 is really good, but not perfect. And so CT is still superior. But I think it's probably good enough that with a little bit more information, we could probably incorporate this into our practice. So that's my case. That's my final thoughts. Any questions here before we sign off?
Yeah, I was actually curious. What type of ultrasound did you say you were using? Were you on a handheld, or did you have one of the Sonosite?
No, it was the machine that they had, which was born like the same year I was born, probably. So it was like it was a Toshiba. I don't know what it was, but like a refrigerator machine that had to like wheel in next to her, and the cord was like in the next room or something. But it was good enough. It was like 20-year-old machine probably, but I was able to see the optic nerve no problem.
Is there anything else in your practice or your reading that would increase, the diameter of the optic nerve sheath that could kind of lead us down the wrong pathway? Are there conditions that that tend to, affect this, where somebody comes in, we really think it's going on, but it's due to some other process?
Yeah, I mean, I think one question that hasn't been answered is, what medical processes actually cause the optic nerve sheath to get bigger, and what rate? Because we think about, elevated intracranial pressure, not just in trauma, but like in pseudotumor cerebri or benign intracranial hypertension. That's been looked at as well. And, the results are sort of varied. And I think it's because there's probably a natural swaying of intracranial pressures. Probably goes up and down, up and down. So I think depending on when you look at the optic nerve sheath diameter, it's probably a little bit bigger or a little bit smaller. And I think also in younger kids, you have to use different values. So the optic nerve sheath is not the same size in younger children. It's a little bit smaller. I think the other thing to keep in mind is that you need a cooperative patient that can keep their eyes still, or a comatose patient that can keep their eyes still, because you have to take pretty careful measurements. We're talking about millimeters, so that can make it challenging if they're moving their eye all around. And you can also have some artifacts. Sometimes the optic nerve will shadow in a certain way, and people tend to measure it a little bit thinner than it actually is. I think that you have to take careful measurements. You have to have some practice in it, and you should always do it bilaterally.
As far as causes of increased optic nerve sheath, just kind of did a quick search. I feel like a lot of them are going to be related to the causes of papilledema, which a lot of those are pretty scary as well. So I think either way, it's a good test to at least pick up on things.
Yeah, I think that we could all use work on our ophthalmologic exams, and even there's a nice study out there that even internal medicine docs that have been doing using their ophthalmoscope for many years still can't do it accurately. So at least me in the emergency department, who I may do it once or twice a shift, a lot less than some other doctors. It's always a challenging exam. So I think that there's still a place to use this to supplement the rest of our exam. So I think, like in all point of care ultrasound, you have to use it in the clinical context. It's just one piece of the information that will help you, kind of risk stratify these patients. Cool. Well, thank you all from UC Davis, and this was fun. We should do it again.
Our pleasure.
Yeah, thank you.